USMLE-style question, ST segment elevation myocardial infarction, STEMI, and transmural infarcts. A 62-year-old man with a history of hypertension, hyperlipidemia, and smoking presents to the emergency department with severe chest pain that started 2 hours ago. The pain is described as crushing and radiates to his left arm and jaw. He is also diaphoretic and nauseated. His vital signs are BP 160/95 mmHg, HR 110 BPM, and RR 18 min. ECG shows ST segment elevation in leads 2, 3, and AVF. Troponin 1 levels are significantly elevated. Which of the following is the most likely pathophysiologic mechanism of his myocardial infarction? A. Partial coronary artery occlusion with subendocardial ischemia. B. Complete coronary artery occlusion with thrombus formation and transmural ischemia. C. Coronary artery spasm leading to temporary ischemia. Coronary artery embolism leading to ischemia in the left ventricle. E. Acute inflammation of the coronary artery wall with vessel narrowing. Answer B. Complete coronary artery occlusion with thrombus formation and transmural ischemia. Explanation. This patient is presenting with ST segment elevation myocardial infarction, STEMI, which is characterized by complete coronary artery occlusion, often due to thrombus formation on an atherosclerotic plaque, leading to transmural myocardial ischemia. Pathophysiology of STEMI and transmural infarcts. ST segment elevation on ECG is a hallmark of transmural infarction, where there is complete occlusion of a coronary artery, typically caused by a ruptured atherosclerotic plaque and subsequent thrombus formation. This occlusion prevents blood flow to the heart muscle, resulting in myocardial necrosis that extends through the full thickness of the myocardial wall, i.e., transmural infarction. The transmural infarction is often most severe in the subendocardial region, which is most vulnerable to ischemia due to its location at the end of the coronary artery branches. The infarcted myocardium releases markers like troponin into the bloodstream, which can be detected as elevated troponin 1 levels in this patient. Why the other answers are incorrect. A. Partial coronary artery occlusion with subendocardial ischemia. This describes non-ST segment elevation myocardial infarction, NSTEMI, where there is partial coronary occlusion leading to subendocardial ischemia, but not complete transmural infarction. C. Coronary artery spasm leading to temporary ischemia. Coronary artery spasm can cause Prinzmetal angina, which results in transient ischemia and chest pain, but not permanent myocardial infarction. It typically causes temporary ST segment elevation that resolves when the spasm resolves. D. Coronary artery embolism leading to ischemia in the left ventricle. Embolism causing myocardial infarction is less common and would usually result in ischemia in smaller distal vessels, not the classic transmural infarction seen in STEMI. E. Acute inflammation of the coronary artery wall with vessel narrowing. This is more consistent with vasculitis, e.g. Takayasu arteritis or Kawasaki disease. But these conditions are much rarer and do not typically lead to the same thrombotic occlusion of coronary arteries seen in STEMI. Key takeaways. STEMI is caused by complete occlusion of a coronary artery, usually due to a ruptured atherosclerotic plaque and thrombus formation, leading to transmural myocardial infarction. Transmural infarction affects the full thickness of the myocardial wall, including the epicardial, midmyocardial, and subendocardial layers. ST segment elevation on ECG is a key feature of STEMI, indicating acute myocardial ischemia and transmural infarction. Troponin levels are elevated in STEMI due to the release of troponin from necrotic myocardium.